All right. Hello, everyone. Today I'll be going over the lecture for neuroanatomy and some additional clinical points for the 2024 Jacksonville Brain Bee competition. I want to apologize in advance. I do have a bit of a cold, but I'll make it through this. So, the first half of this PowerPoint will be on neuroanatomy, whereas the second half will get into those clinical points. And I included some extra information for you guys that I just thought was interesting and will help with understanding. But I'll do as best as I can to highlight what you definitely want to know for the Jacksonville Brain Bee competition. And what is just some extra info for your knowledge. I also should mention that everything that I tell you today is also good to know for the national competition, but is not maybe the extent of everything that you should know for the national and international competition. So definitely refer to the Brain Facts book and those resources. We're going to try to cover as much as we can today. Okay, so first, I'm going to get into some neuroanatomy lingo so that we're all on the same page in regard to vocabulary. And so in regard to directions, here is the front of the brain. This is called the rostral or anterior direction. Rostral you could think of as towards the nose. That's helpful for me. The back of the brain is the caudal or posterior direction. Up is superior or dorsal, and down is inferior ventral. And so you'll hear anatomists referring to different brain structures and their direction away from each other using these terms. We also can talk about planes or fields of view. So if I were to cut through the brain along this blue board, that would be a coronal plane that we will be looking at. If I were to cut horizontally or in the direction of the horizon, this would be called a horizontal plane. And then if I cut to the side, showing the side view, it will be a sagittal plane. So now I have a fun little quiz for you all. Label each plane of section. So you can go ahead and pause this video. I'll give you a second to do that. And in a few seconds, I'll go ahead and give the answers. All right, so A is a coronal plane. You could think of it as a crown. You could put the crown on someone and see it from the front view. This is sagittal to the side, and this is a horizontal plane. Now we'll talk about gyral surfaces. So one thing you may notice if we compare a mouse brain to a human brain is that a mouse brain is actually very smooth looking, whereas the human brain has all of these grooves called gyri. And the function of gyri are to enhance surface area of the brain and also lead to enhanced cognitive abilities compared to animals that do not have gyri. So all of these folds allow the brain to fold so that more of your brain can fit into the skull. And so our brain has been able to evolve, and new parts of our brain have evolved, which is not the case for something like a mouse. And you could see comparison to a dolphin brain, they actually also have a lot of these grooves. As we know, dolphins are very intelligent creatures. So I just thought it would be a fun comparison here. So just keep in mind what the function of gyri are. Now we'll get into lobes, sulci, and fissures. We have 4 lobes of the brain: frontal, parietal, occipital, and temporal. And although here these lobes are colored in for us, I'll show us how to identify each of these lobes and what are the landmarks that allow us to know where the frontal lobe ends and where parietal starts, for example. To kind of get into this a little bit, you have fissures. These are deep splits and divisions that divide the brain lobes. One example shown on the right-hand side here is the sagittal fissure, also called the longitudinal fissure, which actually separates the two hemispheres. So it can separate brain lobes or hemispheres, I guess I should have put, but you get my point. And so some examples, we already went over the longitudinal fissure. Another one is the lateral, also called Sylvian fissure, which divides the frontal and temporal lobe, which you would be able to appreciate right here along this black line. I don't know if you can see my mouse, but and I'll show an example of a real human brain to be able to appreciate that lateral fissure a bit better. So here's a good example. If you could see my mouse, hopefully you can over Zoom, I'm tracing the lateral fissure where actually if you were to hold this human brain and put your hand in this area, you would be able to actually physically separate the lateral, the temporal lobe from the frontal lobe. So now we can get into a sulcus or pleural sulci. These are less deep than fissures, but they can also be used to separate the different lobes. They're grooves that produce gyri, which again increase surface area of the brain. So one example of a sulcus is this central sulcus, which is the longest interrupted sulcus ending in a U shape. So if you trace this red line here, that's the central sulcus, and it ends in this big U shape. Everything anterior to the central sulcus is the frontal lobe, and everything posterior or caudal is parietal lobe. Well, I guess we get to the occipital lobe here, but we'll get into that in a moment. But everything immediately posterior, I suppose, is parietal lobe. So we went over central sulcus, lateral fissure. Another sulcus we should discuss is the parietal occipital sulcus, which you actually cannot appreciate from this view. So I'll go to the next slide where we can look at divisions visible in the medial surface of the brain. And here you could see the parietal occipital sulcus, which separates the parietal from occipital lobe. There's some other ones here that you can appreciate from the medial surface of the brain, meaning the inside, but really just keep in mind the parietal occipital sulcus. So now we'll just get a little bit into the different functions of the lobe. So again, frontal lobe is anything anterior to the central sulcus. Its main function is for advanced motor planning, as well as limb and eye movement planning and learning. So in summary, mainly motor control. Parietal lobe is mainly for sensory processing, so receiving and processing sensory input such as nociception, which is pain, mechanoreception, which is for pressure and touch, and thermoception, which is exactly how it sounds, thermo, so temperature. The parietal lobe is also responsible for sensing body spatial position, and this is called proprioception. Temporal lobe, I like to remember this because temporal lobe, tempo, so it's important for processing auditory information, and also it's important for encoding memories. The occipital lobe in general is for visual processing, such as visual spatial, distance and depth, color determination, object and face recognition, and memory formation. So here's a little quiz. You go ahead and pause this video. I'll give you a few seconds and then we'll go over the answers. All right, so what separates the frontal from temporal lobe? This is that lateral fissure. Frontal from parietal, that is the central sulcus. Parietal from occipital, that parietal occipital sulcus, and what separates the two hemispheres of the brain, that will be the longitudinal fissure. So now we'll briefly get into connectivity. This refers to how electrical signals transfer from brain region to brain region. There are three main types of fibers that allow for this transfer of signals. There's association fibers, commissural fibers, and projection fibers. We really just want to focus on commissural fibers, but just for your information, association fibers link cortical areas in the same hemisphere. Commissural fibers link cortical areas in opposite hemispheres, and projection fibers connect cortical to non-cortical structures. I'm going to continue now with this example of a commissural fiber, the corpus callosum. This is a white matter bundle connecting the two hemispheres. So in blue, the corpus callosum is highlighted. And whenever you see an image like this of a coronal slice highlighted with the brain region of interest highlighted in blue, you definitely want to be able to identify this for your neuroanatomy practical. So now we're going to get into the cortex. Cerebrum is another name for the brain, and the brain is broken up into gray matter and white matter. Gray matter is comprised of cell bodies, whereas white matter is made up of myelinated axons. So just keep in mind, what is gray matter, what is white matter. Cerebral cortex is the outermost portion of the brain. It forms an outer shell around the rest of the brain, and for that reason, its name is derived from the Latin word for bark, outer shell or husk. It includes all the different lobes, and it's made up of the neocortex, mesocortex, and allocortex, but really we're going to get more into the neocortex later. The cerebral cortex is also the more recently evolved part of our brain. And so for that reason, it'll be involved in cognitive abilities and so on. So now I want to talk about Brodmann areas. So in 1909, the anatomist Brodmann named brain regions based on cytoarchitectural and histological structure and organization of cells in the cortex. And through this method, he was able to identify 52 distinct regions. And we're not going to ask you to memorize all of these 52 distinct regions, but we are going to ask you to know about 4 of them. So these are labeled as Brodmann area 1 through 52. This terminology is not necessarily much used anymore, with the exception of certain Brodmann areas, such as what I listed here, which are important to know. So some important Brodmann areas are the primary motor cortex, or Brodmann area 4, which you can see here and here. Then there's the primary visual cortex, Brodmann area 17. This is the occipital lobe, right? And we talked about how the occipital lobe is important for vision. Also, primary motor cortex, we talked about how motion is important, motor control is important for the frontal lobe. Well, primary motor cortex is in the frontal lobe. Then we have Broca's area and Wernicke's area, which we'll see are both involved in language, and those are Brodmann area 44-45, line here, and Brodmann area 22, right here. So now I'm going to give a bit more information on these 4 Brodmann areas. Brodmann area 4 is the primary motor cortex. Again, and the landmark is that it's right here next to the central sulcus. Also, here's the primary somatosensory cortex, so they're very close to each other. Just like the name would entail, primary somatosensory cortex is important for sensory information. But anyway, the function of the Brodmann area 4 is initiation of purposeful movement. So on the next slide, I want to show you something called a homunculus. This funny little guy here. This is a representation of a map of brain areas dedicated to motor or sensory processing. So for example, our hands our brain, a lot of our brain is devoted to motor control of our hands and sensory information for our hands, as well as for our lips and our tongue. Not so much for our arms, as you can see from his little arms here, but this would essentially be how we would look like if the size of our body parts were the same as how much of our brain is devoted to these functions. So I just thought this would be kind of fun to know. It's called a homunculus. Also, I just want to point out the structure is not perfectly accurate, and some scientists are working to update the modern day homunculus. Now, Brodmann area 17, the visual cortex. It's important for visual perception and decoding visual information. So being important for vision, a clinical point is that lesions, which means damage, cause blindness. We kind of went into the pathway involving this decoding of visual information during one of our previous lectures, but I'll just briefly go over it now. And so when you have information that goes, that hits the retina, the information is going to then travel from the retina to the optic nerve. It's going to cross the optic chiasm. Optic chiasm is when the optic nerves from the left and right eyes cross over. That's a chiasm. Then from the optic chiasm, information gets to the lateral geniculate nucleus, or LGN. And this helps to decode the information. And then from the LGN to the primary visual cortex. I also want to point out that LGN is for visual information. It is not to be confused with the MGN, or medial geniculate nucleus, which is for auditory information. Now we get into Brodmann area 44-45, which is Broca's area. It's located in the frontal cortex. It's important for speech production and articulation. So an important clinical point here is that damage to Brodmann area 44-45 leads to Broca's aphasia. And so this is when a patient is able to understand speech and knows what they think and want to say, but their output of speech is diminished. So the patient will have trouble getting out the words that they want to say. And also, I guess I should define aphasia, which is a disorder affecting communication. Another name for Broca's aphasia is non-fluent aphasia. And here I have a little video that shows a patient with Broca's aphasia attempting to speak. So now we want to compare contrast Broca's aphasia with Wernicke's aphasia. So Wernicke's area, which is Brodmann area 22, is in the left temporal lobe, right here. And it's for speech comprehension. So Broca's area is for speech production. Wernicke's area is for speech comprehension. So Wernicke's aphasia is when the patient is able to produce speech but cannot comprehend language. And this could be both in the spoken and written form. So the patient will be able to speak pretty perfectly in regard to getting words out quickly. But the words that they will be saying don't really make sense and don't go together. And they also have the inability to comprehend language. And I have a video here so you can see an example of a patient with Wernicke's aphasia, also called fluid aphasia. Going back to the neocortex, this makes up the majority of the cerebral cortex and contains 6 layers. So we're not going to ask you to memorize all these layers or know their connections, but just keep in mind that the neocortex is made of 6 layers. That essentially allows communication between different parts of the cerebral cortex as well as the thalamus, which we're going to get into later, which is a relay system in the brain. So we're just going to briefly get into some clinical points related to the lobes. So frontal lobe lesions. The prefrontal cortex, if you were to touch your forehead, essentially you would be touching where your prefrontal cortex is. And I know we said that the frontal lobe is mainly for motor control, but it does have other functions as well. So in the case of the prefrontal cortex, its main function is for socially appropriate behaviors. So for example, if you ride your bus to school, you know that a socially inappropriate behavior would probably be to like eat mayonnaise from a jar on your bus, right? So your prefrontal cortex keeps you from doing that, even if you love mayonnaise that much. So understandably, a clinical point here would be that lesions to the prefrontal cortex can lead to depressive, manic, or impulsive behaviors. There's actually been cases where tumors near the prefrontal cortex leads to patients having socially inappropriate behaviors, and once the tumor is removed, their behavior goes back to normal. Another case of a frontal lobe lesion is called FTLD, or frontal temporal lobar degeneration. And here's an example of a patient's brain with FTLD. You can see all of the frontal lobe atrophy. So whereas the gyri should be tight, like I showed on previous slides, you can see all of this is very loose and degrading, and the cells are dying. And so here, patients experience same symptoms as someone with a prefrontal cortex lesion would experience, as well as amnesia, non-fluid aphasia, and dementia. In addition to frontal lobe atrophy, it also includes atrophy of the hippocampus and amygdala, which we'll get into later. So mainly here, you just want to know frontal lobe, although its major function is in motor control, it also, the prefrontal cortex is for socially appropriate behaviors. And FTLD is a neurodegenerative condition that leads to atrophy of the frontal lobe. I don't know if I'm aging myself here, but one famous example of an individual with FTLD is Bruce Willis. Not sure if you've seen any of his movies, but he was diagnosed with FTD. Now getting into parietal lobe lesions. Lesion to the right side of the parietal lobe can lead to hemispatial neglect, which is the inability of the patient to see or draw the left side of objects. So for example, if a patient is drawing a house on a piece of paper, they will not be able to draw the left side of the house. Another symptom for right side lesions of the parietal lobe is called alien limb syndrome. And this is the feeling as though your hands or limbs are not in your control. So for example, if I'm holding a book with my right hand and I'm reading, my left hand may slam the book closed. If I go to reach for a doorknob to open a door with my right hand, my left hand may slam the door closed. So those are some examples of alien limb syndrome, feeling as though your hand is not in your control and even has a mind of its own. Left side lesions of the parietal lobe can lead to autopagnosia, And this is the inability to localize or orient different parts of the body. This makes sense because we said that the parietal lobe is involved in proprioception. And then one clinical point you want to keep in mind is Gerstmann syndrome, which is the inability to identify fingers by name, difficulty performing simple math tasks such as addition, subtraction, and agraphia, which is loss of previous ability to write. So here you don't necessarily need to know right versus left side, but just in general that these patients can experience hemispatial neglect, alien limb syndrome, issues with sensory processing, and Gerstmann syndrome. Some more examples of parietal lobe lesions include those of the primary somatosensory cortex, which is in the parietal lobe, and it causes impairment of two-point discrimination, which two-point discrimination is when, for example, your friend puts two pencils, the pointy tip of the two pencils, puts it on your arm, some distance away from each other, but not too far from each other. Your two-point discrimination allows you to know that it's two objects that's touching your arm and not just one object. But individuals with lesions to the primary somatosensory cortex have impairment of two-point discrimination, so they may only feel one pencil on their arm and not two. Also can have issues with localization of touch, such as if you were to take a pencil and run it down your arm, the patient may be unable to know the location of the pencil on their skin. Position sense, 3D perception, and recognition of writing on skin by touch. So again, it's all sensory info. Temporal lobe lesions, for example, it's important for auditory functioning. So the temporal lobe, again, is important for processing and identification of sound. And lesions here can cause difficulty localizing sound, such as like where sound is coming from, or can lead to deafness. Occipital lobe, again, in general, is for vision. Primary visual area can lead to blindness, and lesions in other parts of the occipital lobe, again, are still in relation to vision. So depth perception, distance judgment, spatial orientations. So a good way to, yeah, I wouldn't recommend like memorizing all of these, but as you notice, as we go through, parietal lobe all has to do with sensory information, temporal lobe all has to do with auditory information, occipital lobe all has to do with vision. And then frontal lobe has to do with motor control as well as cognitive function and socially appropriate behaviors. Okay, so now we get into the limbic system. We're moving outside of the cortex now into the limbic system. The limbic system is important for memory, emotion, autonomic, and hormonal homeostasis. And lesions here cause memory dysfunction and emotional changes. Part of the limbic system is the hippocampus, which means seahorse, actually. The function of the hippocampus is formation of new memories and learning. Here in blue, you can see the outline of the hippocampus, and it is in the shape of a seahorse, kind of. And that's from where it gets its name. And a clinical point, an important clinical point about the hippocampus is that it is among the first brain regions affected in Alzheimer's disease, or AD. AD is the most common neurodegenerative condition characterized by symptoms that slowly destroys memory and cognitive function. And it's likely that you currently know someone or have known someone with Alzheimer's disease. And here is an example of a healthy brain, whereas here is an example of a brain with severe Alzheimer's or a case that has already severely progressed. There are two main proteins that are found to be aggregated in AD brains, and you do want to keep these in mind. These are beta amyloid plaques and neurofibrillary tangles, so plaques and tangles. And actually, what's interesting about plaques and tangles is we don't know if these are a cause of Alzheimer's disease, if they cause Alzheimer's disease or are a result of the illness. So some people believe that we need to reduce the presence of plaques and tangles in order to treat Alzheimer's disease, whereas some believe that plaques and tangles are just a result of the illness. There's currently no cure for Alzheimer's, but one treatment that recently received FDA approval, I believe it was middle of last year, is lecanemab, and this does reduce plaque buildup. The cause of Alzheimer's is currently unknown, but some risk factors include age. Age is actually the biggest risk factor because AD is most common in the elderly population. Also, genetics and the environment can contribute as well. Some genetic risk factors surround apolipoprotein E. We'll get into that a little more in the next slide. So apolipoprotein E, or ApoE, is a gene that comes in several forms, ApoE2, 3, and 4. So if you have ApoE2, a copy of ApoE2, this is actually quite rare to have and is believed to increase your resilience against getting Alzheimer's disease. So it reduces your risk. ApoE3 is the most common copy to have. It doesn't increase or decrease your risk of getting AD. And then ApoE4, if you have one copy of ApoE4, it doubles to triples your risk of getting AD, while having two copies increases one's risk by 8 to 12-fold. So also lastly, the function of ApoE is believed to be involved in making a protein that helps carry cholesterol into the bloodstream. So what are some important things to keep in mind for Alzheimer's disease? Two main proteins that are aggregated are plaques and tangles. Age is the biggest risk factor. But we also have some genetic components as well, such as ApoE. ApoE2, it enhances resilience. ApoE3 is most common, and ApoE4 greatly increases your risk of getting Alzheimer's. Here I just want to briefly talk about Braak staging, which is a method used to classify the degree of pathology. So there are 6 Braak stages, and this helps to explain the level to which tangles have spread. The level to which tangles have spread throughout the brain. So in the early stages of Alzheimer's disease, tangles are mainly found in the hippocampus and then begin to spread throughout the cortex and even into the occipital lobe in late stages. And so Alzheimer's disease not only affects memory from the hippocampus, but then starts to affect cognitive abilities as it progresses to the neocortex. Amygdalas, this is derived from the Greek word for almond, right here. You can see my mouse. Its main function gives emotional significance to external or internal sensory stimuli. And here's some examples of how it does that. But yeah, what you want to know is it gives emotional significance to external or internal sensory stimuli. So if we talk about damage to the amygdala, it would make sense that it would lead to some emotional disturbances. And we'll talk about that on one of the next slides. But here I just want to point out the anatomy of the amygdala. It's more rostral than the hippocampus. So if we were to make coronal sections through the brain, you would first hit the amygdala, and then you would get to the hippocampus, which again, seahorse shape. More rostral is the amygdala here. So now getting into clinical significance of the amygdala, which I touched on just a little bit. Since it gives emotional significance to stimuli, it makes sense that the amygdala is involved in anxiety disorders, PTSD, phobias, and personality disorders. So one example is if you experience trauma, you may start feeling anxiety if you're in a similar situation. So for example, war veterans may experience flashbacks that bring them back to their traumatic event if they hear, for example, there's been cases of veterans having flashbacks during July 4th and New Year's when there are fireworks going off and they sound like explosions. So it brings them back to war zones where they experience traumatic events. And so the amygdala is altered in all of these conditions. Oh, so we'll go to the next slide. Now I'll talk about the basal ganglia. This is a collection of regions primarily responsible for different types of motor control. It's made up of the striatum, globus pallidus, subthalamic nucleus, and substantia nigra. And I'll talk about each of the structures on the next slide. So the striatum, you can't really see it because it's covered by all this blue, but it looks striated, kind of like strings. It's comprised of the caudate nucleus, nucleus accumbens, and putamen. So right here is the caudate nucleus, nucleus accumbens, and then putamen. And likewise, nucleus accumbens, putamen, caudate nucleus. The functions here are just for your information, but just, know that they're part of the basal ganglia and be able to identify them. And they're all involved in motor control. Nucleus accumbens does mediate emotion as well, but mainly for movement. Globus pallidus is for, again, movement related. A little bit of a hint for identification. The globus pallidus is kind of like the ice cream cone, whereas the putamen is like the ice cream. So I don't know if that's helpful. That's just what helped me when I was learning it. And so one other thing to point out is this is a more rostral brain slice. We were to keep making cuts, we would get to the globus pallidus and are no longer able to appreciate the nucleus accumbens. Also, I guess I kind of skipped over this. If you're wondering how I know that this is more caudal and that this is more rostral, I can kind of tell that this is more rostral because it's smaller. And like the more rostral in the brain you are, the more the brain is in kind of a V shape. So I don't know if that's helpful, but that's one way that I'm able to tell that this is more caudal. I'm now getting into the substantia nigra. It means dark substance, also located within the midbrain, and it is comprised of two portions, the pars compacta and pars reticulata, but we're really just going to talk about the pars compacta. So you can see that dark pigment right here. So the pars compacta contains dark pigment that's made from neuromelanin producing dopamine neurons. And we talked about dopamine a little bit during a previous lecture, that it's important for feelings of reward in some parts of the brain. But in the substantia nigra, dopamine is mainly functioning for motor control. So I'm going to get into an important clinical point now relating to dopamine neurons in the substantia nigra. And that clinical point is Parkinson's disease. And so this top image here, if you can see my mouse, you can see that dark pigment. And this bottom image, that dark pigment is gone. And so Parkinson's disease occurs when these dopamine neurons die. And that's actually the pathological hallmark of PD. And patients experience symptoms of what we call TRAPS. So that's tremor, rigidity, akinesia, or loss of voluntary movement, and postural instability. They'll have stoop posture, shuffling gait, and a variety of other symptoms. Also, just for your information, although PD is characterized by this abundance of motor deficits, there also are many non-motor symptoms these patients tend to experience as well, which is quite interesting, in my opinion. The cause of PD is unknown in most cases, but there are some known genetic and environmental risk factors. And the biggest risk factor is age. So PD is most common in the elderly population, age 65 and up. But I guess I will mention that there are some forms of PD called early onset PD, where patients they experience symptoms starting before age 50. That's early onset Parkinson's disease. Another pathological hallmark of PD is this formation of Lewy bodies in neuronal cell bodies, which you can kind of see in this image here, or in neurites, which you can see here and here. And Lewy bodies are comprised of aggregated, misfolded protein called alpha-synuclein, along with there are other components in Lewy bodies, such as damaged organelles. But people tend to consider the main component being alpha-synuclein. And if there's mutations to alpha-synuclein, it actually can cause Parkinson's disease. Or mutations to the gene encoding for alpha-synuclein, I should say. Kind of similar to Alzheimer's disease, when I talked about how it's unclear if plaques and tangles are a cause of AD or if it's just a result of AD. Similarly, with Lewy bodies, it's unclear if they are a cause of PD or if they actually may protect neurons from damage. And this latter idea comes from the fact that patients with early onset Parkinson's disease, which most often occurs from mutations in PINK and Parkin, they get early onset Parkinson's disease. And these patients typically do not have formation of Lewy bodies. So that has led some to hypothesize that Lewy bodies actually protect the patient from getting Parkinson's disease earlier in life. And if these early onset PD patients had Lewy body formation, they may have gotten it later in life, around age 65, for example. In regard to treatment, there's no known cure, but the most common method to help manage symptoms is treatment with L-DOPA. L-DOPA is the precursor to dopamine, and it is able to cross the blood-brain barrier. This is essentially a barrier that prohibits factors from your periphery from getting into your brain. Some things can cross this barrier. You have to have a certain size and composition. And L-DOPA actually is able to cross the blood-brain barrier. And once it crosses, it's then converted to dopamine in the brain. So I know I said a lot there. I actually study Parkinson's disease, so I maybe gave you quite a bit of information here just because it's my main interest. But just to help summarize what you should know, the pathological hallmark of Parkinson's disease is death of dopamine neurons. If you see the substantia nigra, be able to identify healthy from diseased brain. You have symptoms of TRAPS. Again, similar to Alzheimer's, age is the biggest risk factor. Know that alpha-synuclein is the main protein believed to be involved, and that when it's aggregated and misfolded, it makes up Lewy bodies, and that L-DOPA is treatment. Now moving on to the thalamus. The thalamus serves as the main relay station for your brain, and all motor and sensory signals pass through the structure with the exception of smell. And here are some examples, but really keep in mind that the thalamus is the main relay station for your brain for motor and sensory signals. Hypothalamus means below thalamus, hypothalamus. It's the central regulator of homeostasis, and it helps form links between the neural and endocrine or hormonal system. So thalamus is the relay station, hypothalamus is for maintaining homeostatic conditions. Thalamus, below the thalamus is the hypothalamus. You can't really appreciate the hypothalamus from this angle. These are, well, you don't necessarily need to know that these are called bodies. The hypothalamus is more rostral compared to the thalamus. An important clinical point to know is Korsakoff syndrome. This condition causes damage to the thalamus and hypothalamus. It's a memory disorder resulting from vitamin B1 deficiency that is most often caused by alcoholism, but also can be caused by dietary deficiency, eating disorders, or side effects of chemotherapy. So vitamin B1 deficiency causing memory disorder, most often caused by these factors. Now we get to the cerebellum. Cerebellum means little brain. Here's a representation here, so you can see how much smaller it is compared to the rest of the brain. But although it's really small compared to the rest of the brain, half of all central nervous system cell types are located in the cerebellum, which I think is pretty amazing. And its function is to facilitate movement by correcting them to achieve goals, maintain balance, and perform cognitive and emotional control. So if you've ever tried to balance on one leg, you can thank your cerebellum for that. Now the brainstem is comprised of the midbrain, pons, and medulla. We already talked a bit about the midbrain when we got into substantia nigra and so on. So here's the midbrain, pons, this big kind of oval shape, and then the medulla. And actually, if you were to keep moving down the medulla, you would get to the spinal cord. And here's the cerebellum, where it looks like a tree kind of structure. That's kind of the best way to identify the cerebellum. It looks like a tree. So here are the general functions for the midbrain, pons, and medulla. Mid motor movement, which we talked about with Parkinson's disease. Pons is for unconscious movements and processes. Whereas, and we'll get into a clinical case that will explain this a little better. And then the medulla is, it controls heart rate and breathing. So this is a good example of some brain regions that we've had for quite some time compared to the cortex, which is more recently evolved. So you can see that the brainstem is mainly involved in just keeping us alive and allowing us to move, whereas the cortex is for the advanced motor planning and cognitive abilities. So here's a clinical point to help explain this function of the pons for unconscious movements and processes. So insult to the pons, such as an infarct, hemorrhage, or trauma, can lead to locked-in syndrome. And this is a condition where the patient becomes completely paralyzed, except for the muscles that control their eye movement. So they retain the ability to have consciousness and think and reason, but they cannot move or speak. They can only control their eye movement. Now we'll get into cranial nerves. There are 12 pairs of cranial nerves. They're involved in both sensation, movement, or both. Here you can kind of look at cranial nerve 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So here you see that cranial nerve 12 is actually anterior to cranial nerve. And you can come up with your own mnemonic. There's a few out there, but back when I was taking anatomy, what helped me was this mnemonic: O, to touch and feel very green vegetables, for olfactory, optic, oculomotor, and so on. Here's a table that lists them out a bit better. So you do want to know the cranial nerves 1 through 12, along with what their names are. So for example, cranial nerve 5 is the trigeminal nerve, but we don't expect you to know all the functions. And we do want you to be able to identify them. So for example, here, or here, where you can see the midbrain, pons, and medulla from the anterior and posterior view. Actually, from the posterior view, you really can just appreciate the trochlear nerve, which looks like a little mustache. But from the anterior view, you could appreciate all cranial nerves except for cranial nerve 1. So I would suggest printing out this picture and just trying to label the cranial nerves from here. And yeah, have fun. Also, there's a website that actually has the answers to this. It's called neuroanatomy.ca. There's a cranial nerve section where it outlines all of the names here for you. So I'll be able to, I would recommend being able to label something like this, or if we were to give you a cartoon image of the cranial nerves. Now getting into the spinal cord. There's 4 different sections of spinal cord: the cervical spine, thoracic, lumbar, and sacral. So I would suggest just being able to identify cervical from thoracic, lumbar, and sacral. Sacral, I guess, is the easiest to identify. Cervical is quite large. Lumbar looks like this H kind of butterfly structure. Maybe just for your info, maybe you know someone with sciatica, which is causes pain that radiates from your down your leg, and this is caused by nerve damage to L5S1. So in the lumbar and sacral region. Now to talk about the meninges. So now to talk about the meninges, it's made up of 3 components: dura mater, arachnoid matter, and pia mater. And essentially, it functions to protect the brain and spinal cord. It contains cerebral spinal fluid, which helps to cushion the brain, and it provides structural support for vessels. So the outermost portion here of the meninges is the dura, followed by the arachnoid matter, which arachnoid matter you can remember because it looks like spider webs. And then the innermost is the pia mater. So that also brings us into the ventricles, which functions to keep the brain cushioned with cerebral spinal fluid, or CSF. And this CSF is produced in the pia mater by a structure called the choroid plexus. So what's important to know here, just know what the meninges are, the three components they're made up of, and what is the outermost, middle, and innermost part of the meninges. It's also good to know what CSF is, that it flows through the ventricles. So what is the innermost component of the meninges, outermost, and middle? Go back here, innermost is pia mater, outermost is dura, and middle is araculoid matter. So that concludes our neuroanatomy portion. Now I'm just going to briefly get into some additional clinical points that are recommended to know. But if you would like some practice with identifying some of the neuroanatomy that we went over today, this website is a great resource and where I got most of these images today. It's called neuroanatomy.ca. It's a great website for learning most structures. You could quiz yourself. It's kind of like brain flashcards, so super helpful. I even have used it in graduate school, so it's a really great resource. Definitely a great resource. So let me make sure. Okay, so now to get into some additional clinical points, we're going to start off now by talking about Huntington's disease. It's a neurodegenerative condition causing uncontrollable movements, such as chorea, loss of coordination or ataxia, difficulty swallowing, and changes to thinking, behavior, and personality. It's caused by the trinucleotide repeat expansion in the HTT gene, and the HTT encodes for a protein called huntingtin. The brain regions affected are the basal ganglia and cortex, and there's currently no known cure. You can see here an example of a Huntington's disease brain where there's all of this cortical atrophy compared to a normal healthy brain. So things to know: Huntington's disease causes uncontrollable movements, loss of coordination, as well as some cognitive and personality changes. It's caused by trinucleotide repeat expansion. Yeah, it causes all this cortical atrophy. Tourette syndrome is a disorder involving repetitive movements or unwanted sounds or tics that cannot be easily controlled. The example of tics could be repeatedly blinking eyes, shrugging shoulders, or blurting out unusual or offensive words or sounds. The frequency and severity of tics often lessen or become controlled with age. The cause for Tourette syndrome is unknown, but there are multiple brain regions that are impacted, and those are all involved in habit formation, such as the basal ganglia, thalamus, and frontal cortex. And these tics are, they could be completely out of the control of the patient. So, like I said, they could become controlled with age, but in some cases they remain completely uncontrollable by the patient. Now there's cerebral palsy. It's a group of conditions that affect movement and posture. It's caused by brain damage, often prior to birth, but can also occur at birth or early infancy. And symptom severity greatly varies from individual to individual, but some symptoms include stiff muscles, exaggerated reflexes, rigidity, ataxia, tremors, and trouble with swallowing. Multiple sclerosis is an upper motor neuron disease of the brain and spinal cord. It results from the immune system attacking oligodendrocytes, which, if you recall, are the myelinating cells of the central nervous system. and their myelin sheaths, leading to neurodegeneration. Disease course can be characterized as either relapsing remitting, during which the patient experiences periods of symptoms and then improves, or it could be progressive, in which case symptoms worsen over time. Also, a patient could start out as being having relapsing remitting MS, and then later on it could turn into progressive form. Complications involved in MS include muscle stiffness or spasms, weakness or paralysis, and cognitive problems. Interestingly, it's more common in women than in men, and MS is far more common in countries with temperate climates, and exposure to the sun, actually, when a mother is pregnant, may decrease later development of MS in children. So there does seem to be a variety of environmental factors at play here, and there's no known cure. ALS is a progressive upper and lower motor neuron disease, causing death of motor neurons in both the brain and spinal cord. The mean survival time from when a patient starts experiencing symptoms of ALS to time of death is typically only 2 to 5 years. There have been some rare cases during which individuals have lived longer, even 20 plus years. But the condition is typically fatal due to respiratory failure. Symptoms often begin with muscle twitching and weakness, trouble swallowing or slurred speech, and eventually leads to inhibiting ability of muscles needed to move, speak, eat, and breathe. The cause is most often unknown, but there are common genetic causes, including mutations to C9, well, with the most common genetic causes being mutations to the C9orf72 gene, which actually was discovered here at Mayo Clinic, Jacksonville by Dr. Rosa Rademacher. And now to date, there are additional genes that have been implicated in